Good evening, everyone. We will begin with session 4 on end of life and palliative care. Let's begin by welcoming our keynote speaker, Dr. M.R. Rajagopal, the founder of Pallium India and adjunct professor of global oncology, Queen's University, Canada. His initiatives to remove regulatory barriers in the availability of oral morphine for pain relief have contributed to the amendment of the NDPS Act of India in 2014, a government policy on palliative care in the state of Kerala in 2008, and Government of India's National Program for Palliative Care in 2012. The international organization Human Rights Watch honored him with the Alison Desforges Award at Los Angeles in November 2014. In 2017, a documentary film titled Hippocratic 18 Experiments in Gently Shaking the World, based on Dr. Rajagopal's contribution in palliative care, was released by Moonshine Agency Australia. He was named one of the 30 most influential leaders in hospice and palliative medicine by American Academy of Hospice and Palliative Medicine in 2017. In 2018, Dr. Rajagopal was honored with Padma Shri, the fourth highest civilian award given annually from Republic of India. Can we welcome him with a round of applause, please?
Good evening. I've been listening to several enlightening talks. The thought crosses my mind, like every one of you, I have only about 10 to 15% chance of dying a sudden death. 85 to 90% chance is that I will go through a period of prolonged illness. With luck, it could be something like cancer. I can get it over in a year or two. Or it could be something dreadful, like dementia, Parkinsonism, one of the neurological disorders. Almost at the end, fag end of the last session, I heard a question from there. It was Varsha, who asked, with all this talk, what happens to people with this living with this neck pain like me? What kind of support will be there for someone who is unable to lie down properly? Yes. Maybe we need to remember a quote from Eric Castle, an American doctor and bioethicist, that it's a person that suffers, not bodies. As it happens, all our medical advances, especially in the last 3/4 of a century, have been aimed more and more and more microscopically at the body. Somewhere, the human being becomes totally insignificant. I fear that happening to me. I fear all your attention being focused on my organs. Varsha, I already repeated your question. On my body, each of my organs, on microbes, on my chemistry, that will be very interesting. And your attempts at correcting my chemistry, I fear, will add more and more suffering to me in those many years that I would be living with a major illness. And I would like, in this less than half an hour that I have left, to focus on that aspect of it. This is about longevity and healthy aging. Healthy aging is not only when your health is reasonably okay, right? Even at that time, I hope you will not abandon me. Today, the medical science tends to. In my state of Kerala, according to the National Population Study, more than 1,70,000 elders live alone in single member households. I couldn't find exactly the same kind of data for the country, because at national level what they seem to give, what they call health single member households, seems to include people with a live-in domestic help, or people who are living in some homes. This number are people totally alone. And this happens more and more. This data is from 2015. 10 years down the line, it must be much, much higher. But that's not only for those the poor people in our rural areas. It's happening more and more for reasonably affluent people also. Loving daughter or loving son carries the person when one spouse has died because they are alone to the 17th floor apartment in Bangalore and lock them up. Their world is lost. They are disconnected. Please promise me that you will not forget this. This is a standing definition for health. Not only absence of disease or infirmity, but physical, social, and mental well-being. I hope you will remember that when you are planning every healthcare aspect, including your technology. Do you do it in the hospitals today, or do you look only after the body? What attention is given to social and mental well-being, leave alone physical well-being, including that neck pain that Varsha talked about. And I want to remind you, everybody in the healthcare profession, I said doctor's duty, but in the bioethics unit of ICMR is defining the healthcare provider's duty. You have a duty to relieve my suffering officially. It is to cure sometimes, relieve often, comfort always. There exists no exception to this rule. Physical well-being. Even basic pain relief reaches less than 4% of the needy in this country. 96% plus people are living with significant pain, moderate to severe pain. How can we take pride in that healthcare system which ignores human suffering like that? I showed that image. Now, I did not know that I did not know pain management till I came to palliative care. I thought I knew. The doctor treating me would not even know that she or he doesn't know, unless you learn the science of pain medicine. And this strong opioid is something that does not reach 96,000 of people. And if you think, oh, strong opioids, addictive, let me tell you, once you understand it, once you use it properly, it is much less harmful than your NSAIDs that you prescribe right and left. Dr. Sankhamitra is a British oncologist of Bengali origin who does charity work in the northeast of India. And he says this, you need to remember this, because most of you belong to the last category. The poor die in misery of neglect, the middle class die in misery of ignorance, but they die better. If you have money in the pocket, you are sentenced to rigorous solitary confinement in an intensive care unit with no friendly hand to hold. As I say this, some people will be in pain because their own personal experience in the family. At that time, when the most important thing for me is a hand to hold and the ability to say a final word of farewell, to give love, to receive love. Those are the only things that matter. I am an anesthetist. I was an intensivist. I know that intensive care is very precious in the right context. But this new disease of intensive careopathy, which came into being only in the last quarter of a century, where dying people are shut up there is something that there is no justification to. It's an Indian disease. It doesn't happen in Western European countries, where 90% of people are taken off life support systems if their disease is no longer responsive to curative treatment. And another infliction of suffering by the healthcare system, my God, look at the numbers. This, as you notice, the problem is less in high income countries, less in low income countries because they do not have healthcare. They are safer. And because middle income countries have healthcare, this catastrophic health expenditure happens. And in our own country, 5.5 crores are Indians are pushed below poverty line by catastrophic health expenditure every year. Hey, remember, health is physical, social and mental well-being. This is more than 4% of the population in a year on whom we are destroying health. How can that be justified? I've been mourning about problems. What can we do about it? 11 years back, World Health Assembly, the decision-making body of World Health Organization, gave us a solution. I am a palliative care physician. I am just trying to sell our own specialty, but this is the solution. Palliative care is not only end-of-life care. Palliative care is not only treatment of cancer. Palliative care is treatment of all serious health-related suffering. And the World Health Assembly asked all member countries, integrate palliative care into healthcare across the continuum of care, from the beginning of the suffering to the end, not only for the dying person, in primary, secondary and tertiary levels of care. Which means a few crazy palliative care professionals cannot do this unless every clinician learns the fundamental principles of palliative care. It cannot be done. Is that possible? I can tell you it's already happening. It's in the curriculum now. MBBS since 2019, nursing since 2021. The new generation, it will take some time, implementation gap, but they will learn it. But practicing physicians will have to learn it, otherwise they will laugh at us. Now, doing this across the country cannot be done by professionals alone. We found a man in that house during the monsoon in Kerala who, on morphine, pain partially, mostly received, but feeling sleepy, holding up an umbrella within his home because the roof was leaking. He had no money to repair the roof. Healthcare, the job is done when the morphine is dispensed, or can this be done? I can't remember the All India Institute of Medical Sciences having a department for repairing roofs, but the community will make it happen. We have to engage with the community and make them partners in healthcare delivery. I will not talk about it anymore. Dr. Matthews Numbeli, who does that extensively in Kerala, is speaking at the panel discussion to follow. I will happily leave that to him. But engagement of the community is an integral part if healthcare is to be truly healthcare. Today, the curriculum, MBBS curriculum and nursing curriculum include these aspects: pain management and symptom control, end-of-life care, a module called 8COM, attitude, ethics and communication. So as I said earlier, till I came into palliative care, I did not know that I did not know this. So once these come into common practice, I will have to somehow survive till that day comes. What we do in our organization, Pallium India, is have a three-pronged strategy: demonstrate, educate and facilitate. I am mentioning this here because this has to be done at the national level. One alone will not work. We have to demonstrate compassionate, effective, scientific but humane care. We have to educate professionals and the public. And we have to facilitate development of favorable policies. Well, many are already there. Implementation of available policies also, and filling the implementation gap in medical nursing and other professional education. Our facilitation also includes encouraging people to start services and to handhold them till they are ready to walk. So, any healthcare provider here, I would direct your attention to the available courses. Many organizations run it. I have just shown some that our organization runs. There are in-person courses, but there are virtual courses for practically every category, including courses, virtual courses that you can do at your own time. I just wanted to show that link. Go to that page, and our website also gives the contact information for other training institutions in the country. Now, many things have happened in this area. I talk about integration and it looks almost like an unachievable dream. These are things that have been catalyzed by the palliative care community at the level of legislation and policies and programs. India has a national program for palliative care since 2012, and any state government can get funding from the government of India on submission of a program implementation plan on an annual basis. One of the things that we facilitate is work with state governments and national health missions, office of states to educate them about how to apply for this and how to get the funding. The law governing use of opioids, the second one, NDPS, is for the abbreviation, Narcotic Drugs and Psychotropic Substances Act. The law is as complicated as the name. That has been, after so many years, 19 years of efforts, Indian Parliament amended it. Now, if you have a health care delivery system, whether it be a primary health center or a corporate tertiary hospital, any healthcare delivery system, or a one doctor clinic, you can have access, you can get stock and dispense essential opioid medicines for pain relief. That has been achieved already. Only thing is, sometimes state governments do not know about it. So our facilitation team works with interested policies and programs. And if you have any questions about it, again, write to us, and we have people dedicated to that task so that we can facilitate that. The National Health Policy of 2017 includes palliative care. Again, there is a huge implementation gap. At the moment, the National Program for Palliative Care and National Health Policy don't seem to be working in cohesion. Those are things that need to be corrected, or some catalyzing process will have to happen there. And as I said, MBBS and nursing curriculum include the management of suffering, not only treatment of the body. The change that is necessary is for acceptance by the healthcare system that it has a duty to relieve suffering, duty to relieve health-related suffering. And maybe we have to break some of the shackles that we live with without being aware of it, of learning and practicing a body and organ-centered healthcare system. Refocus on the human being. Now, when I talked about this in an audience where there were a lot of healthcare managers and directors, one CEO of a chain of major hospitals looked almost angry and said, "This cannot be done." That delivery of palliative care along with healthcare cannot be done. I hope during the panel discussion, Matthews will have the opportunity to talk to you about Kerala's palliative care policy. May sound like boasting, apologies, but in Kerala, all over the state, everybody who is bedbound or homebound, non-ambulant, gets one visit by a trained palliative care nurse at least once a month. Not much perhaps, once a month. But the difference it makes to human lives is unbelievable. Every one of our panchayats, that is more than 960 something, every one of them would have some 60 to 70, Matthews, please correct me later if I am wrong, people with an indwelling urinary catheter. How would they change it? Every 3 weeks to 1 month? They wouldn't have any money at that stage. Bundling them into an auto rickshaw and taking them for 25 kilometers to a hospital, and often then undergoing a lot of needless expense and needless investigations. In all over Kerala, the palliative care nurse goes and does it at home once a month. The difference it makes to human lives is unbelievable. Not only for the poor, even for the affluent. Going to hospital is not fun. Who goes to hospital as a tourist? That what we call time toxicity, the time spent in hospitals, is being taken away from every bit of enjoyment of life. And the financial toxicity will be considerable. So I told him, when he said it cannot be done, come and see. We are doing it. Okay, not perfectly, nowhere near perfection. But you know the African proverb, a journey of 1,000 miles starts with a step. We have taken that step. And now that the National Program for Palliative Care and the National Health Policy are there, it can happen at the national level. If not all, in every state immediately, a beginning has been made in several states. So when I said, come and see it, we have done it, he said it's not easy. I'll admit that. No change is easy. Going through the trodden path is easy. Breaking a new path is not easy. But then I asked him, why does it have to be easy? All the easy things have been done by somebody else. Only the difficult things are left behind. But if it has to be done, it has to be done. I'm so passionate about it because I am talking about myself tomorrow. These are the most important points that I mentioned. I want a healthcare system for me and for every one of you that takes on the responsibility to address health-related suffering. If a change is to be managed, change is always resisted, and we let it demonstrate the change, educate people on the change, and facilitate management of that change all through. Palliative care, that is the management of health-related suffering, has to be integrated into all healthcare. It cannot be only in standalone hospices and institutions. And finally, the point that he'll talk about more, if this is to be effective, the community has to be engaged. I'll stop there. I know that I have 7 minutes left. That's deliberate because if the chair allows and if there are questions, I can take them. And I'll remind everyone who would like to make a beginning in this, that every single candle lit in the darkness of health-related suffering of 96% of our population, that is most needed where it's darkest. Thank you for your patient listening, and I'll take those things.
So that was a great talk. I have a quick question. So I do translational research at IIT Madras here. So my question is, what is the role of a technologist today, as me, in this whole space of palliative care? Like, do we have a stakeholdership in advancing something or solving some existing gaps in the Indian context?
Very much so. We have a telehealth program. Anybody in India can call us on Pallium India's telehealth line for advice on palliative care. How do we do it? Because of technology. But our abilities are infinitesimally small. We need you to develop it. But that has to go hand in hand with reaching people as human beings also. Technology can achieve a lot only if we don't forget humanity. I listened to a promotional video of a great program in India, I will not name it, where anybody can get a cancer screening. And that promotional video showed a person making a call to somebody in Kolkata. सुनिए आपका रिजल्ट तैयार है, आपको कैंसर है. My God, that was almost criminal way of communicating bad news. That would be use of technology without humanity. They have to be married.
Hello. So, yeah, on your left here, Kash. So you mentioned that why does it have to be easy, right? It's very true. It's not easy. Healthy aging itself is difficult. We have to challenge our physical and mental capabilities to remain healthy, right? That's what the longevity science says. But the question is, the caregiving, it doesn't stop there. It's not just easy. It adds up to huge mental health and stress and financial trouble as well for the caregivers. So you talked about the national health policy. I'm not sure. I have not gone through that. Is there anything that the national health policy is trying to do for the caregivers?
Prakash, the national health policy for the first time included palliative care. Doesn't go into a lot of details. And that's for us to do. I am sorry that in my whole talk I did not mean those unseen martyrs who are unheard, voiceless, caregivers. I mentioned myself with dementia. How will my wife live with me? Even now it's so difficult for her. And if I am having that dementia also, and that is something, thank you for mentioning caregivers. The caregivers are unseen patients, unheard. And palliative care, by definition and practice, is for people with illness and their families. It's a huge area to be covered as we cover palliative care. Thank you.
Thank you, Dr. Rajagopal. My question is regarding opioids. You said that we are not doing enough around painkillers, but we also know that in countries like US where we have health-seeking behavior and they are over quantifying pain, and we are seeing, according to statistics, that over prescribing of opioids is leading to the opioid crisis. How do we mitigate that in this situation in future?
Thank you. What is visible more than anything else is the opioid crisis in the US, Canada, and Australia, where unscientific use after the turn of the century led to the current crisis. We do not want that. There are more than 34 million people in the globe living with addiction. That is serious health related suffering also. But there are 61 million people living with other serious health related suffering. What we need is a principle of balance. Unfortunately, US is so visible. What is less visible, maybe not dramatic because it has been there for about 55 years, are the situation in the Western European countries. Western European countries have that balance. Any doctor can prescribe morphine. provided he or she has had training in it, which now gets through the basic training itself. Every doctor who has got a basic medical training would have learned it. That would be the balance. And Uganda, a low income country, permits nurse prescribing. Specialist nurses trained in it can prescribe morphine, and they have achieved 4 times better than Kerala. And let me boast about Kerala also. In Kerala, access to morphine for pain relief is 16 times more than the national average. And since 1997, it has been available like that, even before the national law changed. So 28 years, no significant diversion to illicit use. I will not recommend free access to opioids. Controlled access to opioids with the principle of balance is what we want. And we have shown that it is possible. Thank you.
Good evening, sir. I'm a postgraduate in geriatric medicine, and since you're an intensivist, I'm curious to know your thoughts on non-pharmacological methods of palliation, like music therapy, art therapy, especially in a country like India. How do you think it would be received? And as a doctor, what is your input?
I'm sure they have a place. I have no doubt about it. So long as it is not promoted as an alternative medicine, as a complementary medical field. One of the problems that we have is many of these complementary fields, once you believe in it, some turn out to be fanatics promoting it. Nothing else needed. This is the answer. So long as it's not an alternative medicine but a complementary medicine, many of them would have great application. And I hope the research that you will do in future will show its value and the way of the correct application. Thank you very much.
Thank you, sir.